Welcome back to KTN Prime. Thank you for staying with us. And we are having an interview with the Cabinet Secretary for Health, Madam Cecily Kariuki. And in the big question related to this interview, we are asking you, do you think that Kenya can achieve universal health coverage? And before the break, we are discussing the managed equipment services and the controversies and the issues that have come up with this. And one of the issues was that counties are now paying almost double the amount that they had been paying since the managed equipment services had went into place in the 2014-2015 budget. And Madam CS, why is this the case now? You have been to Senate, you have been to the National Assembly to answer to this particular question, and the question Kenyans would want to know is why, and counties are saying they have even been paying for this equipment without even receiving this equipment.
There are a few facts that I would like to share this evening with Kenyans. That the managed equipment service is funded through a conditional grant by the national government. The second fact that I would like to share is that as we speak, there is no increase from the 97 million to the 200 million, contrary to what has really been put out in the public. Perhaps we didn't tell our story too well. I'm here to confirm and tell that story. And number three, the conversation from where I sit, I think, needs to migrate and focus on the impact that this investment has had. It's an investment that was made way back from the year 2013 all the way. Contracting processes were complete in the year 2015 and implementation at the middle of 2015. It is an investment that has saved lives. It's an investment that has supported people away from coming into Nairobi or the level 6 referral hospitals, and they are able to get services that they would otherwise not get in the places where they are. I was recently in Lamu, and I can really confirm that patients, 9 of them with the kidney problems that had actually rented houses in Mombasa, 240 kilometers away, had moved families there, are now able to get dialysis on a daily basis in Lamu. I think, Dr. Massey, what would be useful is for us to move away from boardroom conversation or, studio conversations, and to be able to confirm the impact that this investment has had.
There's no denying the impact that it has had, but there's also the fact that some facilities still do not haven't operationalized some of this equipment, yet counties are still paying for it. So yes, there may be some impact or some positive, but there's also the other bit where the equipment is there, they're in boxes, they're in storage. Some facilities, and I have been in one of the facilities, are not even finished construction, yet the county is paying for this particular equipment. So what about that other aspect of the managed equipment services?
I really started by confirming that the funding is a conditional grant by the national government. However, that does not mean equipment should not be functional. So the conversation that I would rather be focusing on, and I am working at this, is what are the reasons that some of the equipment, and when I say some, I really mean some, the fewer percentage, the bulk of them are operational, they are serving Kenyans, is what are we doing to ensure that 100% of the investment is moved to full use, and we are focusing on where the cases is the case or the course is specialized HR. We are capacity building the HR and emerging, then the counties would be able to absorb the HR. And these are fewer cases. We also have cases where we are caught up with a few low voltage electricity availability. Again, we are looking at having the ministry responsible install so that we can then be speaking of 100% capacity in terms of functioning. And that is my focus. I'm working on that now.
So in your opinion, as the Cabinet Secretary for Health, do you think this whole scheme is value for money for Kenyans?
I think it is. I really think it is, if you look at the lives that have been saved just because the investment has been made. But I'm also looking at it and saying, perhaps there were 2 or 3 lessons that would have been taken out now, which would move into any similar investment in the future. One of them is the commitment and the obligations that the counties took on to came a little bit late. So we should have run concurrently as the investment is happening, that there is commitment and actual employment of the specialized staff that were required is one of the lessons that I have taken out. But overall, Kenyans again are good at looking at 1% going wrong when 90% is happening right. I think there's value for money in this. Important, and again, it is a truth that I would want to leave for Kenyans, is that once the duration of the contract, which is a period of 7 years, is done with, all these equipment will revert back to the facilities where they're already positioned, and they will have a shelf life of another up to 5-7 years, depending on how we maintain them. So really, I think it is, I mean, the world is coming to learn how we have done this.
And I'm also looking at it, Madam CS, and some of the equipment that was leased, or rather, quote-unquote, the equipment that was leased, are, for example, surgical instruments. And from where I am and having operated myself, surgical instruments are sort of like cutlery in your kitchen. So is this equipment that is really worth leasing? Because ideally and globally, leased equipment are the ones that are capital intensive. Your MRIs, your CT scans, your PET scans, you know, things that also over time become obsolete. So if we are leasing even minor things like surgical instruments, surgical equipment and trolleys, then questions arise from there, because are these things that we should actually lease?
My understanding is that each of the equipment that comes with accessories was supplied with accessories or the starter pack that was required. That is the information that has been revealed to me. Okay. And then that follows.
Okay, and I know I had been in this process of these managed equipment services from 2014, because I was at the time working in the facilities and knowing what has happened and having seen for myself. Then there's so many questions, but I'll leave it at that and move into the issue of HR, because with equipment, you need human resource. And you appreciate that doctors, nurses, clinical officers, all the healthcare personnel take time to train. So if we are having equipment and no commensurate human resource to operate them, then you find that there's a lag, that we have equipment but we don't have anyone to operate. So which one would be better to do to make sure that you have a pool of human resource and even employ the ones that are out and about who are jobless before you bring in some of this heavy investment in medical equipment?
That's happening, Mercy, concurrently. And, you know, today I was privileged to have the largest cohort of nurses, you know, out of KMTC, 10,800 of them, the highest ever recorded. So it's happening. We are investing. We continue investing in HR, and we'll continue to. However, I think the conversation on the utilization of the equipment and which should come ahead of the other isn't a conversation we can complete as national government or the ministry responsible. It's a conversation which I think need to be held concurrently with the employer. The employer in this case happens to be the county government. So it's very one-sided when I look at it and I'm looking at what should have come earlier. It's also good to note, we obviously, following devolution also, there was a little bit of displacement in terms of how we viewed and how we placed HR. So I think it's a holistic conversation that we need to have. But if we look at the equipment separately, and then we look at HR separately, and then we look at infrastructure separately, then I think our journey from UHC is going to be longer than we intend. Since we do not intend for that to happen, that is why we are bringing all the moving parts together and focusing initially with the 4 pilot counties. We have to address at the same time, with the same import, the issues of infrastructure development, and we've downgraded the import that we are giving that element. We have to focus on HR. It has to be at the heart of realization of UHC. But we've also realized and agreed together with the governors that we want to refocus now onto what we call the basic equipment at all the facilities, the primary health care level. And so there is that reawakening in terms of the approach that we'll be taking. And so we hope we will see all the moving parts go together in a more smoother way.
So the next week, 12th, is International UHC Day, and you know you're launching UHC for the 4 pilot counties. Yeah. What is the plan for UHC? You said, and you have said several times, that it's a journey. So how are we going about this journey?
This journey initially was envisaged to start by having a premium or insurance-based scheme. but the more we interrogated the capability of us having a bigger load onto NHIF at this point in time, the more we were then concerned whether we didn't wish to reform and make that institution a strategic purchaser, as opposed to doing all the things that it does for the time being, which it's done reasonably well in the past, covering about 20% of the population. But thinking of bringing in an additional load then required for us to actually question the capabilities, number one. Number two, and very important, we were looking at issues of the systems in the facilities. We did a quick rapid assessment of the readiness, and what we found was gaps in HR, gaps in commodity availability, both the farms and non-farms, but also a governance framework which required to, again, just be put in place for it to be able to deliver quality care that we are talking about. And so it became abundantly clear for us that you could not, at this point, take on an approach which is insurance-based. So we went on to, or we are taking on an approach which is tax-based, even as we work on the institutional framework as an intermediate stop. It is my hope that inside 1 year we will have reformed and refocused the institution called NHIF, so that we can then be able to move back to the insurance-based approach, because that is what is more sustainable, and that is what we have seen in the other countries is working well.
Talking of sustainability, one of my biggest fears, and maybe many Kenyans would share with this, is that some of these projects and things that are done in the country are individualized as opposed to institutionalized. So what guarantees are there that even when you are not the Cabinet Secretary for Health, or when this administration is not in office, that this process and journey to UHC remains pegged in favor of the citizen at the end of the day?
Fantastic. We do recognize that that has happened in the past. It could happen. Right now we have a space of the next couple of years with the President Uhuru Kenyatta driving these at that level, and the governors in office also driving in their respective counties. We will be working, as we do the pilot, to have a regulatory and legislative framework that is going to outlive the period of these leaders in office currently.
Finally, what do you want to be remembered for as the Cabinet Secretary for Health?
One who led a team that was able to deal with issues of the 26% poor of the poor that always get pushed down below the poverty line because of investing in healthcare. I want to at least have half of that percentage, remembering that were it not for this journey that I am leading on behalf of His Excellency the President, they perhaps would have been below the poverty line. 13%
of Kenyans, that is. Thank you very much. Thank you for your time this evening. That's all that we had for you with the Cabinet Secretary for Health, Madam Cecily Kariuki. I've been Dr. Mercy Korira. Now I hand you over to Abby Agina with business news on KTN Prime.